Welcome to another EduMed video, and this is the next in the series on the ITU ward round, and today we'll focus on the K in the ABCD approach, which stands for the EKG, or in the UK, ECG. We'll cover a little bit about the fact that certain medications commonly used in the intensive care need daily ECGs, and so it's always worth having a look at that. And also we'll cover some things that are commonly missed on the intensive care, which can be picked up on ECG, and also some ECGs which, even though they may look initially quite normal, can show quite sinister conditions. So medications that need ECGs daily. Now this is by no means a comprehensive list, but it just highlights how some of the medications that are very commonly used do require them. Amiodarone, which is one of the most commonly used drugs as an antiarrhythmic in intensive care, especially in those patients who have significant hemodynamic instability. They do certainly prolong the QTC. It's also worth bearing in mind that they can cardiovert patients, the so-called pharmacological cardioversion of AF, and as such, if the patients do go into sinus rhythm, it's worth weaning down or even stopping these medications. Amiodarone especially tends to hang around in the body for many months after its first initial dose, so continuous medication with it is often not required, especially once the underlying condition that's caused the patient to flip into AF has been treated, such as severe sepsis. Clonidine is also significant for increasing the QTC, as is haloperidol and olanzapine. So you can see a lot of the medications that we'd tend to use for delirium management can potentially increase the QTC, and if used in combination can significantly increase QTC, thus increasing the risk of polymorphic VT. So when looking at an ECG, it really is worth assessing what the QT interval is, and often this is calculated by the ECG at the top, and it's worth using this because rather than using an absolute QT interval, the more useful thing is to correct it for the heart rate. As the patient goes faster or slower, it'll either shorten or lengthen the QT interval respectively, so to correct it for the RR interval is important. Another thing that's important to bear in mind when looking at ECGs is picking up those very atypical or very subtle signs. The ECG that you see on the right hand side in the 12 lead is actually a posterior infarct. You can see here that there are ST depressions, quite deep depressions, and you can see some reciprocal changes here in leads 3 and AVF, where there's some ST elevation from the baseline. This is typical of a posterior infarct. These sorts of infarcts, although generally uncommon, can occur, and certainly we see that patients with critical unwellness, such as those on intensive care, certainly do have a high propensity to ischemic heart disease and acute myocardial infarctions. So those patients that you find are persistently tachycardic or have a drop in their blood pressure or rising inotrope or vasopressor requirement in the context of a rising lactate, do think about this and to specifically look for those more atypical ECG presentations of MIs. I cannot emphasize strongly enough how important it is to compare ECGs. Whenever you admit a patient onto the intensive care, it is vital that you get an ECG as a baseline. Often these patients would have had it on the ward because they were critically unwell, or they would have had it on admission to the A&E. However, whichever way you do it, you must have a baseline ECG. You will see over the course of an intensive care stay, patients' ECGs change dramatically, and having a baseline just allows you that ability to pick out what is new and what is old. You should generally have quite a low threshold for requesting an ECG in a patient in intensive care. The bare basics of the things that one would want an ECG for are tachycardias and bradycardias. Tachycardias because they could be dysrhythmias, very common is AF, and AF itself is not a great condition for patients to be in, especially if they've been requiring significant amounts of vasopressor or inotropic support. The lack of the atrial kick can drop your cardiac output by between 10 and 30%, which is not a good state if they've got a low cardiac output state anyway, especially if they've got underlying ventricular dysfunction and failure. Any patient with a rising lactate should be considered for an ECG, because that could be the first sign that the patient has had an MI. Increasing inotrope or vasopressor requirements again could indicate ischemic heart disease and cardiac dysfunction. Finally, those patients more subtly with a hemoglobin of less than 80, but in the context of ischemic heart disease, may well start to show signs of cardiac ischemia with ST depression or even ST elevation, more pronounced Q waves. These things could indicate that the patient actually requires a slightly higher hemoglobin to allow for appropriate myocardial function. So they can be more subtle signs. So certainly if a patient is anemic on the intensive care and you're using a lower transfusion threshold of 70, do have a look at the ECG just to make sure that the patient is not symptomatically anemic, because these patients often are intubated, ventilated, and not able to tell you that they're having chest pain or angina pains. So an ECG is a really important thing to look at on the daily ward round, not just for looking at the QTC, which you need to do daily for patients on regular medications, which can affect the QT interval, but also to compare it to the baseline ECG to look for any evidence of new ischemia, which it's not that uncommon to see. Patients are certainly at a higher risk of MIs, and they will not complain of chest pain simply because they're intubated, ventilated, and often sedated. So this is your best proxy for that.